Can start.
Good morning and welcome to all delegates for today's USG workshop in Hall B. As you all must be knowing, ultrasound has become part of our armamentarium, both in operation theatre and ICU. So all of us must know how to use it in different situations. We can't do nowadays without it. For this session, I would like to invite Dr. Saurabh Anand, who is Chief of Department of Neuroanesthesia and Neurocritical Care, Armamentis, Gurgaon, Artemis, Gurgaon. Before, he was a senior consultant in neuroanesthesia and critical care, Medanta City, Gurgaon. He is also program director of the SNAC Fellowship in his hospital. He has led exclusive live workshop on TCD in 2017 and 2018. He presented his work on USG in Japan and work on TCD in Korea also. He has got 15 publications to his credits, and recently he has published a review article on hyperperfusion syndrome in carotid revascularization. With this, now I will welcome Dr. Saurabh Anand to come on the stage and start the session along with his team. Dr. Saurabh Anand, please.
A very thank you to the SNAC organizers, especially Dr. Indranil and Dr. Jayanti, for the kind introduction. We as a team Artemis, I will say, are conducting these workshops from a very long time, and we, till the time the physical workshops were going on, we were doing quite a bit of transcranial Doppler workshop. In fact, a recent transcranial Doppler workshop with a physical 30 participants we have just concluded 4 months back in our institute as well. So I will take this opportunity to present my team. From my team, Dr. Ashish Chakravarty, Dr. Seema Lachala, Dr. Sweetha Mohan, Dr. Ramandeep Kaur, and Dr. Parul will be presenting the various aspects of POCUS. I will say that a POCUS is actually useful in decision making in emergency and critical care, and it is useful in decision making process, as well as I will say in guiding us into intervention as well. And in COVID pandemic, when the problem was the shifting of the patients to a CT scan unit or to an X-ray unit, the POCUS actually help us delivering care in the patient's bedside. The aim of the workshop is that people should pick up the probe, because in 2 hours it is very difficult to teach each and every aspect of POCUS. But we will make sure that people should start picking up the probe and start practicing ultrasound, because as soon as you are going to pick up the probe and doing it regularly, that will be our aim. So I think the workshop will motivate the participants to pick up the probe and start doing POCUS in their institutes. We are going to start from the basics, and we wanted to stick to the basics in next 2 hours. We are not going for an advanced workshop in these 2 hours. So with a quote from Stewart Brad, I will say, once a new technology rolls over to you, if you are not the part of the steamroller, you basically is going to miss, or you will be on the road. Okay, so pick up the probe and start doing POCUS. With that, I will start the first talk, which is going to be taken by Dr. Seema Lachala, who is a senior consultant and very important team member of my team. She is basically MD anesthesiologist, and she has done a fellowship in IDCC, as well as a fellowship in neuroanesthesia. She is our most important member who is doing POCUS day in and day out. So she is going to start the talk with the basics. I will request the team to just start the video of the basics of ultrasound.
Hello everyone, I'm Dr. Seema Lachala, Senior Consultant, Neuroanesthesia and Neurocritical Care at Artemis Hospital, Gurgaon. I welcome you all to the POCUS workshop. In the next few minutes, I'll be talking about the basics of POCUS under the headings of basic physics, probes, knobology. And in the basic physics, I'll be talking about the ultrasound waves, the significance of sound waves characteristics, principle of formation of image on the screen, various interactions of the ultrasound waves with the tissues and the various artifacts produced during these interactions, and ecogenicity. Now, what is the definition of ultrasound? We know that we humans can hear sound wave frequencies from 20 to 20,000 hertz, and the sound wave frequency more than 20,000 hertz is an ultrasound. So ultrasound in medical practice uses higher frequency ultrasound waves, typically more than 1 million hertz, that is the megahertz. That is why the focus probes, they have frequencies in megahertz. Unlike light which travels through medium, the sound waves, they do require medium to propagate, and we see here the sine curve, the wavelength, which is the distance between the two peaks of same amplitude, is in inverse relationship with the frequency, which is the number of cycles per second. And we can see that the shorter wavelengths, they have higher frequency and vice versa. So the significance of these characteristics is that higher frequency, that is the lower wavelength, they have higher resolution. So higher frequency probes, they give better resolution. So because the tissues, they will receive shorter wavelengths, that means they will receive more ultrasound waves per unit time. So the drawback of higher frequency is that it has high attenuation, causing decrease in the penetration. So the higher frequency probes, they have better resolution, so they will be useful for the viewing of superficial structures only, not the deeper ones. Next characteristic is speed. It does not mean much clinically in the specific tissue, but yes, change in the speed between two different media is important. Speed depends on the density of the medium it is traveling through. So the ultrasound waves, they travel faster in denser medium because the tighter particles are there to propagate the vibrations. Here you can see among these media, air has the minimum density and the hence minimum speed of ultrasound, and whereas bone has higher maximum density and the maximum speed of the ultrasound. Another characteristic of sound wave is amplitude. It is related to the height of the sine wave, and it is correlated to the loudness of the sound waves, that is the ecogenicity. Coming to the principle of formation of image on the screen, we can see that three things are there. Ultrasound waves, they are sent to the tissues, and the reflected ultrasound waves, they are analyzed, and the image is created. So this is the ultrasound equipment. We have ultrasound machine with the screen, and a machine is connected to the transducer through a cord. Now, what is the source of ultrasound wave? Is it the machine itself? No, it is the transducer. And you can see here under the footprint, there are specialized ceramic crystals which are arranged in a particular pattern. And these are the piezoelectric crystals having the property of converting electric current into the ultrasound waves and vice versa. So what happens at ultrasound waves, they send alternating current to the transducer, and the piezoelectric crystals, they get stimulated, producing vibrations, and ultrasound waves, they are generated, and they go to the tissues and get reflected off the tissues, again back to the piezoelectric crystals, which convert these ultrasound waves back to the electric current, and the ultrasound machine analyzes the data collected and produces image on the screen. So this whole thing is called as piezoelectric effect of the ultrasound. Moving on to the interactions of ultrasound waves with the tissues they are traveling through. The various interactions are there that occur at the change of where at the interface, tissue interface, where there is change in the medium. So various interactions which are there are like reflection, the sound waves, they get reflected back. Refraction, there is change in the direction of the sound waves. Attenuation, they are causing the loss of the energy of sound waves. Scattering, it is done by the small moving particles like erythrocytes. And when these interactions are occurring, various artifacts of clinical importance, they are produced. Now, what is acoustic impedance? It is nothing but the resistance to ultrasound propagation as it passes through the tissue. It is directly proportional to the density. Higher the density, higher the impedance. And we can see here the air has minimum density, so the impedance is low. and bone has the maximum density among these media, so it has the highest impedance. Now, what is the reflection of ultrasound waves? It occurs when two adjacent tissues, they have significantly different impedance values. And what happens? Almost all the ultrasound waves, they are reflected back to the transducer instead of penetrating through. So air and bone, they appear as bright white light. You can see lines, as you can see here. This is the rib, and these are the reverberation effect produced by the reflected A lines on the lung ultrasound. Now comes the refraction of ultrasound waves. It occurs when two adjacent tissues, they have slightly different impedance values, causing only change in the direction of the ultrasound waves. And the refraction depends on the angle at which the ultrasound wave enters the medium. It usually is seen at the rounded interface faces between fluid-filled circular structures and the adjacent tissues. And this produces edge effect. You can see here, this is the carotid artery, and the black lines, they arise from the edge of these vessels. They're also seen in case of gallbladder, cyst, vessels, urinary bladder. Now comes the attenuation of the sound waves. It is the loss and absorption of the ultrasound energy through a medium. It can be high and low, and we have seen that air and bone, they have maximum attenuation. And the artifacts produced by the attenuation are posterior acoustic shadowing and posterior acoustic enhancement. When sound enters high attenuating tissues like bone or the stone, the echoes are diminished posteriorly. And you can see here, this is the rib, and the rib shadow produced behind the rib. And this is the shadow produced by the stone. The other artifact is posterior acoustic enhancement, and it occurs when sound enters the low attenuating tissue. So echoes, they get enhanced posteriorly. As you can see here, this is the bladder, and the echoes, they are enhanced beyond the bladder. So here comes the mirror effect. This occurs, this is produced when sound waves, they get bounced off from the strong, smooth reflector surface like diaphragm. So the sound waves, instead of going directly to the transducer, they take a longer time of flight, and they get bounced off back and forth, and the structures, they get flipped. So two images are formed. The true image is above the reflector surface, and the mirror image is below the reflector surface. So the significance of mirror image of liver is that it excludes the presence of pleural effusion. Other artifacts are comet tail artifacts, ring down artifact. Ring down artifact is the B lines. They go down till the bottom of the screen, unlike comet tail artifacts. Now coming to ecogenicity, that is related to the height of the sine wave. And you can see here that it is related to the amplitude of the sine wave. It tells us how bright a tissue appears on the ultrasound image as compared to the surrounding structures. So depending on the ecogenicity, the classification is same as the surrounding tissue. So in anechoic, that means the black image, no echoes, they are reflected to the probe, and all the ultrasound waves, they pass through. And these are seen in the fluid-filled structures like cyst, vessels, bladder. And these are the hyperechoic, that is the brighter or the whiter shadows. More echoes, they are reflected to the transducer as compared to the surrounding tissues. So these are seen in case of bones, stones, pleural lines, right? And this is the hypoechoic area, and you can see here the fewer echoes are reflected to the transducer as compared to the surrounding structures. So these are seen, they appear as darker or gray, like in case of neoplasms or lymph node. Now coming to the probes, which is the most critical component of the ultrasound equipment. We know why, because it is the probe only which has the piezoelectric crystals, which are the generator and the receiver of the ultrasound waves. So there are three basic types of probes: the curvilinear, phased array, and the linear. And each probe has the following parts, like footprint, which is the area that comes in contact with the skin of the patient, that needs to be covered with jelly always to avoid the air interface. There is an orientation marker on one side of the probe, and just the whole thing is the body, and tail is at the end, the end at the end, which is connected to the ultrasound machine through the cord. So while selecting the probe for examination, you have to strike a balance at what do you want to see for, what is the structure of interest you have, and you have to decide between the frequency and the penetration. So right probe for right application is very important. You have to hold it in a pen holding manner, and you have to stabilize the hand, and you have to make very gentle movements at a time to optimize the image, and a good amount of coupling jelly is to be placed on the footprint. Now these are the three focus probes. So this one is the linear, or also called as vascular probe. It is a high frequency probe with the frequency of 5 to 15 megahertz. High frequency means higher resolution, but the drawback is low penetration. So image, the depth achieved is less than 6 to 8 centimeters. It has a linear footprint and a linear rectangular view on the image, and it has maximal spatial resolution. So it is suitable for superficial structures and the procedures. This is the curvilinear probe. It is a low frequency probe with the frequency of 2 to 5 megahertz. Low frequency means low resolution and higher penetration. So depth achieved is 15 to 25 centimeters. It has a curved wide footprint with a curved view on the image, and it has a better lateral resolution. So being a probe of low frequency, it is suitable for the deeper structures like abdominal, pelvic, lung, and cardiac examination. This is the phased array cardiac probe. It is again low frequency probe with a frequency of 1 to 5 megahertz. Low frequency means low resolution, high penetration. So depth achieved is 15 to 25 centimeters. It has a small flat footprint, and you can see here it has a sectoral view, right? So why? Because the piezoelectric crystals, they are packed in the center of the probe to get in between the small spaces like ribs. So it has a lesser lateral resolution as compared to the curvilinear, but it has a better temporal resolution. That means it has the ability to detect and record the rapid movements of heart. So it is ideal for the cardiac scan. Applications are similar to the curvilinear probe, and it is also used in case of cranial ultrasonography. Coming to the orientation markers, they help us in the orientation of the image. So there are markers on the probe as well as on the screen. The probe indicators, they are present on the one side of the markers, as you can see in the image, and they are invariably, they are by default, they are the markers are kept pointing towards the head end or towards the right side of the patient. And there is a screen indicator which corresponds to the indicator on the probe. And you see here that in all general applications and procedures, the screen marker is on the left side of the image. But in case of cardiac scan, you can see here in case of cardiac scan, the probe is always on the right side of the screen. So then comes the scanning maneuvers. These are the probe movements. They help us to focus on the region of interest and to optimize the image. So the sliding is there, you can move up and down, right and left. Tilting is there, you can angle the probe on the longer axis. Rocking is angling the probe on the marker. Rotating clockwise or anti-clockwise, and this is the compression. Coming to the knobology, we know that there is a system control panel with various keys, and this is the power key. To switch on the machine, we have to press it once, and the machine gets on in 15 seconds. And then the next step is you have to select the transducer to view the structure of interest, and then you have to preset the machine, and for this you have to press the examination key, which area of interest you want to see, cardiac, nerve, abdominal, vascular, whatever. So the system automatically adjusts the parameters so that we can get the optimized image. Then comes the modes. There are 4 keys on the right side of the bottom of the panel. So this is 2D, color, Doppler, and M mode. Color and Doppler, they are advanced modes. The basic and the most common 2D and M mode only. So 2D mode is the B mode or the brightness mode. It is a default mode, and whenever you switch on the machine starts in B mode only. So it gives anatomic representation of the structure. So this is the standard imaging modality of the ultrasound, and there are 2 dimensions here, width and the depth. So this is vertical, this is the horizontal axis, and this is a vertical axis, and the structures closer to the probe will be closer to the top of the screen, and vice versa. So M mode, motion mode, that includes a time scale. So it is a structure evaluation over a period of time, and you have a motion versus time display of B mode along a chosen line. So on the horizontal axis, we have time, and on the vertical axis, we have the movement of the structure of interest. So M mode has a good temporal resolution. It detects and records the rapid movements. So various applications of M mode are to evaluate for lung sliding, to rule out the pneumothorax, IVC assessment, E-point septal separation in cardiac scan, and so on. So now comes the depth. It is the first setting that needs to be adjusted when you start scanning, and it tells us how deep we want to scan. And you can see here, there is on the right side of the screen, there is a scale of depth in centimeters, and at the end of at the bottom, the exact value of the depth is displayed. So our goal is to keep the area of interest in the center of the screen to improve the quality of image. So there are 2 keys on the control panel. The upper one decreases the depth, and the lower one increases the depth. Moving on to the next setting that needs to be adjusted is the gain. This is to select the brightness of the image. How bright do we want our image to be? As you can see here, this is a low gain. This is a darker image. It's a very bright image, high gain, and this one is the optimal gain. So there are 2 ways to select the gain. There is a auto gain key and the manual. These knobs are there. When you press auto gain, the system automatically adjusts the gain of the whole image. And when you press the manually, the upper one, it controls the gain of the near field only, the top half of the screen, and the middle one adjusts the gain of lower half of the image, that is the far field, and the lowest most, it adjusts the gain, you adjust it manually, the gain of the whole image. Next, this is the touchpad, and this is the freeze key. When you press this, it stops the live imaging and displays the frozen image. And with this, you can get more time to view your image. And with touchpad, when this is on, with touchpad you can also scroll back the previous frames of image. This is the caliper. So this is to make the measurements, and about 8 sets of calipers can be obtained. And you have to, while making the measurements, you have to shuttle between this select and the caliper keys to make the measurements. And this is the clip. This is to save the movie of your image to 60 seconds of movie. And this is the zoom to magnify the image 2 times. You have to press it once to select the area of interest, and again press it to magnify that area. With this, we finish the basics of POCUS. Thank you. Thank you so much.
Thank you, Dr. Seema. I think with this, we move on to the next presentation. We are going to take all the questions in the chat box at the end of the presentations. We move on to the next presentation from Dr. Sweetha. She's a senior consultant in neuroanesthesia and neurocritical care in Artemis Hospital in our team. She is MD anesthesiology, and her area of interest is epilepsy and art focus and psychological aspects in critical ill patients. I welcome Dr. Sweetha to present her talk.
Good afternoon, everyone. I'm Dr. Sweetha Mohan. I will be talking to you regarding the basics of how to do and how to interpret the ultrasound of lung in the critically ill. Lung ultrasound or point of care ultrasound is a very easy to do, easy to learn bedside tool which will help us in the assessment of acute dyspnea in the critically ill. I will just share my slides. So focus lung or point of care ultrasound lung is done basically to detect causes of acute dyspnea, be it acute respiratory failure or dyspnea because of a cardiac failure. It can also be used for real-time ultrasound guided thoracocentesis or pleural tap as well. So before we go into the details, what comprises the lung ultrasound anatomy? Basically, are you looking at your pleura, your alveoli, interstitium? And when you do ultrasound, you should remember that the ultrasound waves are completely scattered or attenuated by air that fills the normal lungs. So if you're doing ultrasound of a normal lung, you might not be able to assess the lung texture or the lung parenchyma. It relies less on the lung anatomy and more on the artifacts that are resultant of the ultrasound physics of air-filled structures. So visualization of lung parenchyma is essentially basically because of pathology rather than it being of a normal lung. These are the two ultrasound probes that we usually use, which is the curvilinear probe, which is of 2 to 5 megahertz, and the linear probe, which is of 6 to 30 megahertz. Before I go into the probe placements, what are the patient positions that we usually do? So patients can be supine, erect, or in lateral decubitus positions. In supine position, if you keep the ipsilateral arm of the patient above the head, then it kind of helps to open up the intercostal spaces and it will help you to look at the underlying structures more clearly. So what are the probe placements? You start with the vertical placement of the probe between intercostal space as shown here. And this is how you will see. You'll see the skin, the subcutaneous tissue, and the muscles, and you'll see both the ribs and a smooth hyperechoic line, which is the pleural line. This is because your probe is kept here perpendicular to the pleura. Once you see something of interest or some underlying structure which needs to be seen more clearly, then you put the probe in a horizontal position in that same area. Over here, you will see only the skin, subcutaneous tissue, and the pleural line, and you will not be able to see the rib or the rib shadows. So in ultrasound lung, each lung is divided into 6 zones. This is basically for ease of understanding, for ease of handovers, and for documentation purposes. So anteriorly, you draw a line across the lateral sternal line, anterior axillary line, and posterior axillary line, and you intersect these areas, and you will get 2 zones anteriorly, 2 zones laterally. And if you draw a line across the posterior axillary line and the lateral vertebral line posteriorly and divide these areas into zone 5 and zone 6 posteriorly. So essentially there are 12 zones that you have to look at when you do ultrasound lung in patients each number of times. Zone 5 and 6 are basically gravity-based zones. So this is where you will look for mainly pleural effusions, consolidations. When you do thoracocentesis, you will be using zone 6. So the first ultrasound finding, what you will see is the Batwing sign. This happens when you put the probe vertically across the intercostal space, and you will see the rib and the rib shadows as the ultrasound waves do not pass through the ribs. And you will see a smooth, shiny, hyperechoic line, which is called the pleural line. So this ensures that you are correctly between both the ribs. The pleural line is the first tissue air interface that you come across in an ultrasound lung. So this is called the Batwing sign. Now, to look at normal lungs, you have to see the movement of the visceral and the parietal pleura over one another. So this shows that the lung is aerated very well. This is called a sliding sign. So this happens, you can see this happens when the parietal and the visceral pleura are sliding over each other in tandem with respiration. It looks like ants are marching on one line. This shows that this is a normal aerated lung. Presence of lung sliding essentially rules out a pneumothorax. If you want to further evaluate sliding sign, you put on M mode and you can see the dynamic changes of the chest wall and the underlying parenchyma. So if you put the M mode, like I'm showing in this video, you put the M mode, press the M mode again, and you will see this pattern, which is called the seashore sign. Basically, just chest wall will give you a superficial linear pattern, and the normal aerated lung or the mobile lung will give you a granular sand-like appearance, like an appearance on the beach, okay, like this, right? So this is a sign of a normal lung, and this is the seashore sign. When the ultrasound waves reflect off the air from the pleura and the probe surface, so it produces horizontal reverberations, basically producing an image of what looks like your pleural line. So these are basically echo artifacts, and they lie equidistant to the true pleural line. So you can see this is a pleural line, and these horizontal reverberations are there, which are the resultant of the ultrasounds reflecting off the probe and the parietal pleura. This also shows that this is a normal aerated lung. Okay, and if there's absent lung sliding, but if there are A lines, it can still essentially be a pneumothorax, because A lines can be because of an intact parietal pleura also. So a normal lung comprises sliding sign, seashore sign, and A lines. Now let's come to the abnormal findings of lungs. So what are B lines? B lines are basically vertical reverberations which occur when there is fluid accumulated within the interlobular septae. 5 characteristics of B lines are: they always arise from the pleural line, they extend till the bottom of the screen, they look laser-like, hyperechoic, they move with lung sliding, and they completely erase the A lines. So you can see in this, there is, let's see, you can see lung sliding and laser-like, hyperechoic, vertical reverberations which are happening. Likewise in this one also. So in this, there is a confluent B line also, which you can see along with individual separate 4 to 5 B lines. So this shows that the lung is deteriorating, a fluid, more and more fluid is accumulating in this lung. So if there are 3 or more B lines between 2 ribs in a single scan or in a single intercostal space, that comprises what we call as alveolar interstitial syndrome. It could be because of pulmonary edema, pneumonitis, pulmonary contusion, or pulmonary fibrosis. So as you do lung ultrasound serially in the same patient, you will be able to see changes in the lung. So if slowly the patient is deteriorating, initially you see the scan, there is lung sliding, there are A lines, you have seashore sign, then slowly fluid starts accumulating, your pleural line starts getting disrupted, 3 to 4, more than 3 B lines start appearing in the single intercostal space. It slowly become confluent, and then there are bronchograms, shred sign, and pleural effusion, which I will be coming to later. So this schematic representation helps you in determining whether your patient is deteriorating, or with your timely intervention and treatment, whether your patient is improving. This is what I have tried to show you here with the pictures of different stages of progression of the B line. So initially it's a normal lung, then there's 1 or 2 B lines start appearing. Then there are septal rockets, which are essentially 3 to 4 B lines, which is suggestive of a thickened septa. And slowly it becomes what's called glass rockets, when there are more than or equal to 5 B lines in the intercostal space. And this corresponds to your CT finding of ground glass opacities as well. So when the subpleural consolidation starts happening, there are multiple tissue air interfaces which occur. So here, each of those reflect off, and this kind of looks like a jagged hyperechoic edge because of the multiple tissue air interfaces. And this is what is called a shred sign or a subpleural consolidation, or it can even be called pleural shredding. It's not a very smooth pleural line like the one I showed you earlier. Slowly, when the consolidation starts progressing, you'll get what is called hepatization of the lung, when the lung is completely filled with fluid or pus as in pneumonia, or when the lung is completely collapsed as in atelectasis. So you'll get these heterogeneous hyperechoic foci with irregular borders in the subpleural parenchyma. And you can see that this is the liver of the patient, and the diaphragm you can see very clearly, and your lung is essentially looking like the liver. This is called hepatization of the lung. In consolidations, you can see what is called dynamic air bronchograms. Basically, this happens because of some patent airway in between the non-aerated lung parenchyma because of consolidation, and it tends to move with patient as and when the patient inhales and exhales. As you can see, these are hyperechoic peaks which keep moving with respiration. It's going disappearing, appearing, disappearing, appearing, and this is essentially suggestive of a pneumonia. Whereas when you get static air bronchographs, this basically shows that there are air bubbles trapped behind an obstructed airway, seen in patients with atelectatic lungs. In this also you will see hyperechoic peak, but if you can appreciate the difference, this is not moving with the respiration as opposed to the previous video that I showed. So if there are static air bronchograms, it is essentially an atelectatic lung, and if there is a dynamic air bronchogram, then it is a consolidated lung. In an atelectatic lung, or if there's endobronchial intubation, or if there is apnea, then you can get what is called a lung pulse. So you can see that the lung is basically, pleural line is moving in synchronous with the heartbeat. This shows that there is impaired regional ventilation, and the parietal and the visceral pleura are in touch. So the presence of which essentially rules out a pneumothorax. So in atelectasis, you'll get absent lung sidling, presence of lung pulse, and static air bronchograms. So in what do you see in pleural effusion? So pleural effusion, you can see an anechoic area which is seen between the parietal and the visceral pleura. You can see this dark area. This is basically fluid-filled pleural space. So POCUS is more than 90% sensitive and specific for pleural effusions. In this particular video, you can see what is called a jellyfish sign because of the floating lung. In this mode, if you do an M mode, in this sign, if you do an M mode, you'll get what is called a sinusoid sign, basically because of undulating movements of the floating lung along with respiration. So this is while inspiration and this is during expiration. And if you see the distance between the skin and the expiratory lung, and if it is around 15 mm, then you can go ahead and do a safe therapeutic puncture for thoracocentesis. The other sign you can see very easily in pleural effusion is a quad sign, which is seen, like you can see, which is outlined by the pleural line. The lung line, which is essentially because fluid is filled between the parietal and the visceral pleura, and it is outlined by the ribbed shadows. These are the quad sign that suggest that you can have a moderate pleural effusion. What are the signs of pneumothorax? So in an ultrasound can diagnose a pneumothorax with very good clarity. Okay, it takes much lesser time than it takes for you to get the x-ray and get it uploaded and assess it. So what are the signs? So basically there is absence of lung sliding, but you have to make sure that you rule out other causes of absent lung sliding. We can have a barcode sign or a stratosphere sign because the lung is not getting aerated. Then a lung point, presence of a lung point confirms a pneumothorax. So lung point is basically at the boundary between aerated lung and the initiation of the pneumothorax. So in pneumothorax, you will not find any B lines. So absence of B lines are there. A lines can be there from an intact parietal pleura. So this is a barcode sign. If you can see, there is absent lung sliding. If you put an M mode there, then you can see barcode or a stratosphere sign, or it is not the usual grainy, normal aerated lung that you can see. It is basically because there is no aeration which is happening, as opposed to your seashore sign, okay, which shows that the lung is aerated. So these are the two main signs that you have to remember while doing ultrasound. Barcode sign, which basically shows that it is a pneumothorax, and your seashore sign, which shows that there is a normal aerated lung. Then lung point is something which confirms a pneumothorax 100%. Lung point is basically the boundary between the aerated lung and the pneumothorax. And you have to see the lung point in the same pleural line, in the same intercostal space. You have to demonstrate the lung point. So as you can see, this is the lung point, which separates your non-aerated lung from the aerated lung. Okay, and as you can see, this part of the pleural line is not moving at all. There is absent lung sliding, and if you see this bit, there is lung sliding. And if you put M mode, the non-aerated lung shows up as your barcode or the stratosphere sign. Okay, and if you put the M mode where the lung sliding is happening, or where the aerated lung is there, you can see the seashore sign. So this 100% confirms the presence of a pneumothorax. So after all these signs, how do we put everything together, and how do we assess and interpret as to what exactly is the cause of the dyspnea? So in 2008, the Blue Protocol came about, which is the bedside lung ultrasound in emergency. It takes about 3 minutes for you to do it. Ultrasound wise, it is 90.5% diagnostic accuracy is there. Combine these with history, physical examination, and other investigation, the accuracy makes it 100%. So there are essentially 3 points. The upper blue point, which is if you put your upper hand, left hand or the right hand below the clavicle of the patient. The middle of your upper hand is your upper blue point. The middle of your lower hand, if you keep it this way, is your lower blue point. And if you draw an imaginary line posteriorly from the lower blue point to the lateral sternal bladder, then you'll get your PLAPS, where the posterior lateral alveolar and or pleural syndrome. This is where you look for pleural effusions. So this is the Blue Protocol. It is a stepwise assessment to determine what causes acute dyspnea. So first step is to assess whether there is lung sliding is present or absent. If the lung sliding is present, you go on to step 2 and look for A lines or B lines. If there are bilateral B lines, then that is essentially pulmonary edema. If A lines are present, then the cause is extrapulmonary. So you can do a compression ultrasound. If there is DVT, then it is pulmonary embolism. If there is no DVT, look for the Plapp's point. And if there is consolidation over there, then it is pneumonia. If there is no consolidation, then it could be a COPD or an asthma exacerbation. If the lung sliding is absent, again, look for B lines or A lines. If there are B lines, then it is essentially pneumonia. If there are A lines and there is a lung point, then it is essentially a pneumothorax. So this is how you assess patients with the blue protocol for signs for cause of acute respiratory failure. In the same way, like there are different profiles which are there. Anterior A profile is anterior lung sliding with A lines, which is essentially a normal lung. B profile is with lung rockets, anterior lung sliding, that is basically pulmonary edema. C profile is basically any anterior lung consolidation. So this way, with these different profiles, you can figure out whether the patient has pulmonary edema, pleural effusion, or consolidation. So this is another protocol which you can do to assess the cause of acute circulatory failure. Basically, you do an echo, combine the echo and the lung ultrasound to see for causes of obstructive shock, cardiogenic shock, hypovolemic shock, or septic shock, basically. So this is how an ultrasound ultrasound of the lung helps in finding out the cause of acute dyspnea in these patients. It is a very useful and non-invasive tool. It has a very small learning curve, and it has a high sensitivity and specificity for diseases. I hope this has been a very good learning experience for all of you. Thank you. Stay safe and take care, everyone.
Thank you, Dr. Sweetha, for this lucid presentation. With this, we move on to the next. I welcome Dr. Parul from my team, who's an associate consultant in neuroanesthesia and neurocritical care, Team Artemis. She won the gold medal in the post-diploma neuroanesthesia course in 2019 and 20. She is going to take the lecture on airway and compression ultrasound. We welcome Dr. Parul. Over to you.
So good day, everyone. I'm Dr. Parul Sharma, an associate consultant with the Department of Neuroanesthesia and Neurocritical Care at Artemis Hospitals, Gurgaon. So as I say, that the eye sees what our mind already knows. So let's get ourselves going into knowing the focus for upper airways and the deep venous system of the lower limbs so that our eyes don't miss out anything next. So airway ultrasound is a valuable, non-invasive, simple, and a point-of-care ultrasound evaluation for the airway management. The things which we're going to learn here is basically the Sono Anatomy of the structures of the upper airway that involves assessment of the cricoid cartilage, the thyroid cartilage, the cricothyroid membrane, tracheal rings, and esophagus, and side-by-side understanding the practical implication of these. So for any airway assessment for the ultrasound, we need to have the position of the patient being in supine with the head extended and the neck flexed, because we are going to assess the anterior midline aspect of the neck. So we pick the linear probe for the same, and the probe could either be placed in the transverse axis or in the longitudinal axis as shown to you. And we identify different structures in both the planes and we apply them to our clinical practices. So this thing could be applied, the airway ultrasound could be applied either for the confirmation of the endotracheal tube or for the confirmation of the esophageal intubation for that matter, and for confirmation the position of the endotracheal tube. It could also be used in prediction of the size of endotracheal tube in the pediatric populations during the procedures of the percutaneous tracheostomies and for the procedure of percutaneous cricothyrotomy, as well as for the assessment of vocal cords and as an adjunct for the post-extubation stridor evaluation. So let's get started first with the Sono Anatomy. So what we're going to do is the patient is positioned supine. We are going to put our linear probe into the transverse axis over the suprasternal notch, just over the suprasternal notch. So when you're going to put it in a transverse axis, the view that you're going to get is this. So there will be a hollow black midline structure that is basically the tracheal lumen. You're going to see this shiny membrane, shiny structure, which is there, it is the air mucosal interface. And then you're going to see this horseshoe-shaped hypoechoic ring-like structure. These horseshoe-shaped hypoechoic structures, these are the tracheal rings. And when you move the probe in a longitudinal axis, like the right side of the probe is kept there only, the foot is kept there, and the left is moved into the longitudinal plane, what we're going to see is again this hyperechoic shiny structure, which is the air mucosal interface. And as you can see, multiple small hypoechoic string of bead appearances. And these are all the tracheal rings. So the importance of this is over here, we can identify the tracheal ring 1, 2, 3, and so on. So this space between T2 and T3 can be efficiently used for our percutaneous tracheostomies. So we demarcate, we put the landmark over here using the needle over the skin, and we delineate our space, and we also identify any important structures in the form of the neck vessels on either side of this and then the transverse axis, so that we avoid injury to the anterior neck structures. And I say that this could also be employed in confirmation of the endotracheal tube position. So first, as you can all identify now here, the string of bead appearance or the string of pearl appearance as the tracheal rings, and this is the hyperechoic line. This lumen, this thing which you're going to see in the lumen of the trachea is basically the endotracheal tube. So this is called the double lumen sign or the double tract sign. And for confirmation of the position of the endotracheal tube, we can actually inflate and deflate the bulb of the tube using the saline. So this is the cranial end, the caudal end over here. I had inflated with saline, now I'm deflating it. And this is going to show the approximation of the tube to this air mucosal interface. This is where my bulb was. So this helps me identify the final location or the position of my endotracheal tube, and I can anytime adjust it accordingly. As I move cranially, in my transverse axis only, what the structure I'm going to encounter next is basically a hypoechoic lying C structure. So that is a cricoid cartilage. And these are again, this is the air mucosal interface, and these are because of the air reverberations in the lumen of the airways. This thing, when you're going to move the probe in the longitudinal axis, after the string of bead appearance of the small hypoechoic rings end, you see a big bump, a hypoechoic bump. That is the cricoid cartilage. And as we keep moving cranially towards it, you can appreciate here a very shiny hyperechoic structure. This is the cricothyroid membrane, because the cartilage next cranial to this is a thyroid cartilage. So this again can be used in identifying the landmark of a cricothyroid membrane. So in patients where we identify that there could be the anticipated difficult airways, we might end up being into a CVCI condition. What we do is, in a preoperative period only, we get our ultrasound, we demarcate the cricothyroid membrane so that it becomes more easier and convenient for us to delineate the structure pre-procedure, pre-operatively, and this reduces the failure rates of this procedure because we demarcate it by putting a needle over the skin, and that is basically at the cranial end of the cricoid cartilage. So identifying the cricothyroid membrane by the anatomical landmark is the thing which is mostly responsible for the failure rates of this procedure whenever it is needed. Over here, there's an identification, see, as you can see in the video, the air mucosal interface, the string of bead appearance of the tracheal cartilage, and as we move cranially, the first hypoechoic bump, the large bump that you're going to see is a cricoid cartilage. And as I move further cranially, this shiny structure, which is transcending from this bump, is the cricothyroid membrane. You can appreciate here. Over here, you can mark it with your surface landmarks, and the further this hypoechoic structure which you're going to see is a thyroid cartilage. Now, another importance of identifying this cricoid cartilage is basically the measurement of the subglottic diameter, which is of great help, especially in pediatric population, because it is found to have a great correlation with the size of the endotracheal tube, be it cuffed or uncuffed. So this subglottic diameter, we basically measure using a cricoid cartilage as a window. So we identify the cricoid cartilage in the transverse axis and near the lower edge of the cricoid cartilage, because we know that the subglottis is basically the space between the true cords and the cricoid cartilage. So the subglottic diameter is usually measured at the lower edge of the cricoid cartilage, and it gives a very good correlation with the outer diameter of the endotracheal tube in the pediatric population especially. And it's found to be much better correlating that as compared to the modified Coles formula. Then we ascend further upwards, and what we're going to identify here in the transverse axis is basically the hyperechoic triangular structure. So this is the thyroid cartilage. And besides the thyroid cartilage, in the transverse view, what we can see is a fleshy hyperechoic structure. This could be the thyroid gland. So it is important to identify this structure, especially in cases of percutaneous tracheostomies, where we want to know if our thyroid gland is falling into the position so that we can avoid any injury to this subsequent structure and the major vessels involved in it. This thyroid cartilage is also employed as a window for the evaluation of the vocal cords. So through this window only, when we have our probe placed transversely over the thyroid cartilage, what we're going to appreciate is in hyperechoic inverted V-shaped structures. So these are the vocal cords. Adjacent to the vocal cords are the vocalis muscle that we're going to see. So this you can appreciate, this is the thyroid cartilage. So why this is important? Because in few procedures in the patients who are basically put up for the thyroid surgeries, or even in our neuro patients with the CP angle tumors, or the tumors which are compressing onto the 10th nerve and all, we can have the vocal cord palsy. We can have abnormalities with the movement of the vocal cords and the symmetry of the vocal cords. So it becomes really important for us to identify it pre-operatively so that we can actually put up those patients who require the detailed laryngoscopic evaluation anytime before the procedure. So by evaluation of the vocal cords, we assess not only the movement of the cords, but also the symmetry or the asymmetry in the movements. So the evaluation is done with the patient normally lying quietly and then during phonation. So this video, I'm showing you the, the movement of the vocal cords, so you would be able to appreciate better. This was the patient who was intubated, and then this was the procedure when we're taking out the endotracheal tube and extubating. As you can see, after that, we made the patient say something, and the vocal cords are seen adducting totally. Both the vocal cords, both the sides, right and left, they were moving equally. Then comes an important structure that is important to identify is the esophagus. So how do we identify it? Again, our linear probe in the transverse axis put over the suprasternal notch. We identify the trachea here, as I told you already, the horseshoe-shaped hypoechoic rings that you're going to see. Just move your probe a little bit on the left, laterally on the left in the same plane. So what you're going to see is a collapsible structure, maybe a collapsed structure, that is an esophagus. So this is the trachea, transverse axis, suprasternal notch. You're going to see the horseshoe-shaped hypoechoic thing. This is the hyperechoic air mucosal interface. And then on the left side, this is the collapsed esophagus that we are appreciating here. Now, if there is an endotracheal intubation over here, we can see that this collapsed structure remain no more collapsed, and it basically is distended. Over here, I've tried to put a Ryle's tube into it for you to appreciate that if there is anything in the lumen of the esophagus, it is definitely going to give you some air mucosal interfaces. It's going to be distended. So that is going to give you the confirmation whether your endotracheal tube is there in the lumen of the trachea or it's there in the esophagus. So this is sometimes very important in the condition, wherein you cannot wait for 2 or 3 breaths for the capnogram to pick it, like in patients with the cardiopulmonary arrest or in pulmonary embolism. It's so because there is no any single tool or an indicator for confirmation of the endotracheal intubation. This could also be misleading, however, in conditions when you have emphysema, when you have excessive fat and all. But this could definitely be a very quick indicator for either an endotracheal intubation or an esophageal intubation for that matter. So that is enough for the focus for the upper airways. Now let's move on to the focus for the deep venous system of the lower limbs. So the most important thing is to know that what we are seeing. So we'll be evaluating the deep venous system of the veins of the leg. So I'll be doing it for the knee and above. So, we are going to evaluate the popliteal vein, which continues and ascends further upward as the femoral vein. This is also called as a superficial femoral vein. It is joined as a tributary by the deep femoral vein in the mid-thigh, and just before it continues as a common femoral vein, it is joined by the great saphenous vein and then further as the external iliac above the level of inguinal ligament. So for the evaluation of the same, we are going to use a linear probe because it's a superficial structure. Important is the position of the leg of the patient. So we generally say that the patient is frog-legged. That means the hip is externally rotated and the knee is flexed. So this basically makes it valuable. It makes the deep veins, the femoral veins, more superficial. The important clinical pearl here is usually during the evaluation to make the patient feel comfortable and for the patient to allow you doing it for a considerable time. You can put a pillow under the knee and to evaluate the popliteal vein, as we are going to put the probe into the popliteal crease, sometimes it may become difficult for us to identify the popliteal vein. So if the patient is able to sit up and hang the leg by the side of the bed, so we can do that. We can hang the leg by the side of the bed, provide the support, and we can actually insonate through the popliteal fossa. Another thing that could be done to make the veins more prominent is to provide a Trendelenburg's position. We can give a little bit of head up if the patient cannot lie in the Trendelenburg's to make it more comfortable, but that also makes the vein more prominent. So the most important, most superior technique for our POCUS, the bedside quick evaluation, is the compression technique. And how much do we have to compress? It's just enough to start compressing or collapsing the artery. Just a quick overview about your anatomical location. Most of us are already aware at the level of inguinal canal, we know it's VAN, that is vein is most medial, artery, and then the nerve. Then we move down, as I told you, it is joined by the great saphenous vein, mostly from the medial side. The deep saphenous vein, they say it mostly joins in from the lateral side, and then it further continues as the femoral or the superficial femoral vein, and it then elopes into the musculature, finally comes out into the popliteal fossa as the popliteal vein. So throughout, right from the inguinal ligament up to the popliteal fossa, we are going to evaluate it at every 2 centimeter. We are going to provide compressions at every 2 centimeter, and we're going to see the patency, the collapsibility of the parallel vein. So this image is basically just at the level of the inguinal ligament. Over here, this is medial. This is of the left leg. So this is the femoral artery, and this is the femoral vein, the common femoral vein. This thing, as you can all appreciate, that the vein can also be identified with the presence of valves in it. So this is the transverse axis view. This is the femoral artery. This is just 1 or 2 centimeters below the inguinal ligament. And as you all can appreciate here, this is the great saphenous vein, which is actually joining in this common femoral vein. And I was compressing it just enough to collapse my artery, and I could see that my vein is completely collapsible. That means, and there, I do not see the evidence of any thrombus herein. The similar view I've provided, but in the longitudinal axis, that we can evaluate both in the transverse and the longitudinal planes. You can appreciate the presence of valve here in the vein, and this is the great saphenous vein joining in as a tributary to the common femoral vein. Now, as we move further down into the thigh, at the level of the mid thigh, the artery becomes more anterior. So this because basically is your deep femoral vein, which joins as a tributary to our femoral vein or the superficial femoral vein. And as I descend further downwards, you can see it eloping and emerging into the musculature. Then we reach the popliteal fossa. Over here, we have to actually examine the popliteal vein at the level where it is trifurcating. The important thing to understand and remember at this point is, in the popliteal fossa, there is pop on the top. That means the vein is actually on the top of the artery. So I've used a color Doppler here to show you that this is the popliteal vein and this is the popliteal artery. As you can see with the pulsatility of the blood flow, to appreciate that the vein is on the top of the artery. You can again apply the compression and you can appreciate the collapsibility of the veins. So these are just two images to make you believe that there could be, that we can even actually identify the presence of a thrombus via POCUS and a bedside ICU in the patients where we suspect a DVT. So this is the femoral artery, and onto the medial side, this is the common femoral vein. As you can see, the lumen, it is not that hypoechoic, rather it shows the presence of a thrombus. And this is the common femoral vein with the great saphenous vein joining in, and there is a lurking thrombus over here in the lumen of it. Thank you so much. I hope I had the privilege of your time, and this would help you get through the POCUS for the upper airways and the DVT.
Thank you, Dr. Parul. With this, we quickly move on to the next presentation by Dr. Ramandeep Kaur. She is addressing the issue of EFAST and ONSD, which we all do for non-invasive measurement of intracranial pressure in our neurocritical care setup. Dr. Ramandeep is a consultant in neuroanesthesia and neurocritical care in our department of neuroanesthesia and neurocritical care in Artemis Hospital. We welcome Dr. Ramandeep.
Hello everybody, I'm Dr. Ramandeep from Artemis Hospital, Gurgaon. I'm going to talk about EFAST examination. It is a quick sonographic assessment in trauma patient. FAST stands for Focus Assessment with Sonography in Trauma. Here we are looking for free fluid within the peritoneal cavity and the pericardial cavity, and we assume it to be blood. When E is prefixed to FAST, it is called extended FAST, and here we additionally see for hemothorax and pneumothorax. Now, before going to each viewpoint, I want to go into the basis of EFAST examination. First, fluid appear black on ultrasound. They are anechoic shade. Secondly, we are looking for free fluid, and we are not looking for fluid within the anatomic structure. Thirdly, the anatomic structure, they are round in shape, and when they are budding towards each other, they meet at some angles. So we are looking for angular free fluid or the angled anechoic shadows. Okay. Now coming to the first viewpoint, that is the right upper quadrant viewpoint. We need a curvilinear probe. Place the probe between 8 to 11th rib in the mid-axillary line with the indicator of the probe towards the head. Now we have to track down whole of the right upper quadrant. So we have to move the probe from posterior to anterior, from up to down, so that we can cover whole of the right upper quadrant. I'm playing a video of normal right upper quadrant view. So first we have to look for the diaphragm. Above the diaphragm is the lung. Below the diaphragm is the liver. Then below it is the kidney. There is a space between liver and the kidney that we will call as Morrison pouch or the hepatorenal pouch. And then we have to track down the probe till the inferior pole of the kidney, where there is right paracolic gutter. So whenever there is into the right upper quadrant, the fluid first collects into the right paracolic gutter, and from there it trickles down to the Morrison pouch. So most common site of collection of fluid is seen in the Morrison pouch, but we should not miss seeing the inferior pole of the kidney, because if the injury is too trivial or if the patient has come too early, if we have not checked the inferior pole of the kidney, then we will miss some small blood and it can be fatal afterwards. So please look for inferior pole of the kidney and the right paracolic gutter whenever you are seeing the right upper quadrant. This is a pic where we are showing there is liver, there is kidney, and the Morrison pouch with the fluid in between. This is one important point for the right upper quadrant. The second important point is that there is a normal mirror artifact in these cases. The ultrasound waves, they hit the diaphragm. Diaphragm is a spexio-reflector. It reflects the waves to the liver and it redirects back to the diaphragm and it goes back into the ultrasound probe. But what happens? The ultrasound machine presumes that sound waves travel in a straight line. So the liver appears above the diaphragm. This is possible only when above the diaphragm, the lung is well aerated. If there is fluid between the diaphragm and the lung or between diaphragm and the liver, we will miss this normal artifact. Okay. This Artifact is also seen on the left upper quadrant also. So the other viewpoint is the left upper quadrant viewpoint. Here we have to put our probe in the posterior axillary line in 6th to 9th rib, and the probe indicator is again towards the head. We have to look for free fluid above the diaphragm, below the diaphragm, that is between diaphragm and the spleen, and between spleen and the kidney. And you can see the video. So first we will try to look for the diaphragm. We have to roll down our probe accordingly. Then there is spleen, there is kidney, there is lung. So the most common site of collection of blood on the left upper quadrant view is the between diaphragm and the spleen, or around the spleen, not between spleen and the kidney. This is because spleen is small, it is movable, and the hilum of the spleen is highly vascular and prone to injury. Okay. We can see here in this picture, there is spleen and the diaphragm and the collection of blood between spleen and the diaphragm. The mirror artifact is also seen on this quadrant also. Now coming to the third viewpoint, that is the pelvic viewpoint. Here we have to put a curvilinear probe just above the pubic bone. For transverse view, we keep the probe indicator towards the right. For the longitudinal view, we keep our probe indicator towards the head. First, we have to look for the bladder. In male, there is a pouch between bladder and the rectum that is called the rectovesical pouch. We have to see for free fluid over here. And in female, there is additional uterus and vagina between the bladder and the rectum. So we have two pouches, one between the uterus and the bladder, and another between the rectum and the uterus. So we have to see for the collection of blood between these also. As in this video, we can see there is some collection of fluid but under the bladder. So this is important finding. Now there are two more viewpoints. One is the cardiac viewpoint and second is checking for the pneumothorax. I'm not going into detail about them because they will be dealt in detail in other topics. Now coming to the FAST protocol. If FAST is positive and patient is stable, we have to take the patient for CT. If FAST is positive and patient is unstable, we should rely on our FAST examination and immediately shift the patient for surgery. If the FAST is negative and patient is stable, we can have a follow-up CT afterwards. But if the FAST is negative and patient is unstable, we should find for other causes of bleeding like extra-abdominal, rectoperitoneal, and we should go for surgery accordingly. So this was some nutshell about the FAST examination. I hope it helped you. Thank you. Hello.
If the organizers can just play the second presentation of Dr. Ramandeep, which is on ONSD.
This session, I will tell how to measure optic nerve sheath diameter. It is a simple bedside, non-invasive method of assessing elevated intracranial pressure. First, I want to talk a bit about the anatomy of optic nerve and the sheath around. If you look at the anatomy of eye, there is anterior chamber, there is lens, there is vitreous, the retina around, and posteriorly there is emergence of the optic nerve. Pia mater is surrounding the optic nerve, and next to it is the arachnoid space where the CSF is filled, and then there is the dural sheath. Now this arachnoid space, it is in direct communication with the brain via the CSF. So that means if there is increase in the ICP, that will be transmitted to this arachnoid space by increasing the CSF pressure, and then there will be dilatation of the optic nerve sheath surrounding this subarachnoid space. And measurement of this dilated optic nerve sheath will give us a clue about elevated intracranial pressure. Now coming to the procedure, we have to tell the patient to close his eye. We'll put a tegaderm over the eye, and then a copious amount of jelly will be put. We need to put a copious amount of jelly because we don't want to transmit any pressure to the eye. Otherwise, patient can have oculocardiac reflex or patient can have injury to the globe. We want to avoid both of these. We need to examine in both longitudinal and the transverse view, and then we'll take a mean of that. Now, once the probe is fully adjusted, then we'll have a view like this. There will be a globe, optic nerve, and the sheath around. Now, with the help of a video, I will tell how to measure the optic nerve sheath diameter. First, we have to track down the probe to get a good picture of optic nerve sheath and the optic nerve. There should be demarcation between the optic nerve and the sheath around, and you can see the inner black is the optic nerve. There is thin black outside, that is the CSF filled arachnoid space, and then the sheath. Then we'll take one marker and we'll measure from the vitreoretinal interface to this marker up to 3 mm below perpendicularly. Now, with another marker, I'm going to measure the optic nerve sheath diameter from one inner edge of the optic nerve sheath to the other inner edge of the optic nerve sheath. The normal value of the optic nerve sheath is 5 or below, 5 mm or below. If the value is coming more than 5 mm, we suspect elevated intracranial pressure. As in this, we can see the value is 0.62 centimeter or 6.2 millimeter. But then I would say that we need to have serial measurement of ONSTs because a single value cannot predict everything. If a patient has come like with a value of 5, 5.5 and he is clinically doing okay, then we can start our management, and slowly if we find that the ONST measurements are increasing, then it should alarm us and we should act promptly. Then coming to the sonographic quality criteria for optimization of ONST measurement, it says that firstly, measurement should not be made through the lens. Even the edge of the lens should not be available. Secondly, sonographic differentiation between the nerve proper and the arachnoid space must be obvious. And thirdly, they say that the outer border of the arachnoid space must be identifiable, and because it will give a correct ONST measurement. Thirdly, they say in ideal situation, the dark should meet the dark. That is, the nerve should meet the vitreous without interposition of thick ecogenic layer of the posterior sclera. Then, as I already told you, the correct standardized measurement is that if you take 3 to 4 millimeter from the vitreoretinal interface, as this portion of the sheath is highly distensible. So we want to measure this portion of the sheath. Then it is highly recommended to measure ONST bilaterally and in more than one plane. This is an important quality assurance method. And if we are doing ONST trend monitoring, review the previous recorded images. It will ensure us that we are using the same measurement techniques and we should correlate our pictures accordingly. Then in the hand of expertise, if a good view is there, we can get additional information like flattening of the posterior globe. It gives us the picture that it can be chronic raised ICP rather than the acute raised ICP. The tortuosity of the nerve can be seen, and we can have further more idea about the optic nerve sheath and the optic nerve, and we can interpret it. So in the end, I would like to say that it is important tool in ICUs, in neuro ICUs. We should keep doing ONST measurement. We cannot send the patient to CTs every time, but we can definitely do ONST measurement 2 to 3 times in a day, and we can land into a decision about the rising of the intracranial pressure. Thanks.
Thank you, Dr. Ramandeep. With this, we'll quickly move on to our next presentation on 2D ecography by Dr. Seema Lachala again. Doctors, over to the organizers for the eco presentation. If there are any questions, you please free to put them in the chat box. We will try to answer those questions in the chat box itself.
Hello everyone, I am Dr. Seema, Senior Consultant Neuroanesthesia and Critical Care at Artemis Hospital, Gurgaon. I welcome you all to the bedside basic cardiac ultrasonography. Mind it complements only and does not replace the comprehensive echocardiography. So in the next few minutes, I'll talk about the basic imaging windows, views of the point of care echocardiography and IVC assessment. We know that sometimes the clinical examination is not enough to resolve the situation, and the focused echocardiography helps us to evaluate the cardiovascular dysfunction, what is happening, where to focus, where to intervene, and this helps in guiding the clinical therapy. The goals of point of care echocardiography is that it helps to evaluate the global function of the heart, left ventricular function, right ventricular size and function, and we see pericardial sac and IVC too. So we see that why is our patient hypotensive? What is the cause of the hemodynamic instability? What is the status of the left ventricular function? Is it normal, hyperdynamic, or depressed? What is the right ventricular size and function? Are there any signs of right ventricular strain present? Is there any, the gross valvular or wall motion abnormality? We look for any pericardial effusion, and is the status of IVC normal, collapsible or distended, and can more fluids be tolerated by the patient? So these are the things which we have to see for when we do the point of care echocardiography. For doing the cardiac scan, the patient should be supine with the head of bed flat if feasible, and some views they are better seen in the left lateral decubitus position because the heart becomes closer to the chest wall, and sometimes even the abduction of the left arm helps us giving the better window because the intercostal space increases. And the probe selection for this cardiac scan is phased array probe. We know this is a low frequency probe with the frequency of 1 to 5 megahertz. It has a less resolution but scan deeper into the chest. This probe has a small footprint that also helps us to scan better through the narrow rib spaces. It has a high frame rate per second, that is the temporal resolution is much better with the phased array probe, and so it can demonstrate the cardiac movements very efficiently. It has an orientation marker on one side that corresponds to the screen marker on the right side for all the cardiac applications. So the display of with this probe is the sectoral, as the piezoelectric crystals, they are focused in the center of this footprint. So once you start the scanning, you have to adjust the device settings like depth, gain, and focus to get the best possible image. There are scanning maneuvers which help us to focus on the region of the interest and to optimize the image. This is sliding. You can move the probe up and down, right and left. Tilting, here you angle the probe on its long axis. Rocking is when you do the angling on the marker of the probe. And in rotation, you move clockwise or anti-clockwise for the better image resolution. As you can see here that this is the long axis of the body, and heart with its base, this is base of the heart, this is apex of the heart. It is an angle to the long axis of the body. So the long axis of heart is along the right shoulder and the left hip of the patient, and it cuts through the apex to base. And you can see here there is vertical bisection of the left ventricle, apex, and the aortic center of the aortic valve, which lies approximately here. And this one is the short axis of the heart that cuts heart from anterior to posterior, and this is perpendicular to the long axis of the heart, and it is along the axis of left shoulder to right shoulder, right hip of the patient. So the short axis of heart, it gives us cross sections of the ventricle. So these are the basic 4 imaging windows: parasternal, apical, subcostal, and suprasternal. So in this presentation, we'll talk about the parasternal, apical, and the subcostal only. As you can see here, that this picture, it shows it's a very beautiful picture depicting all the views, basic cardiac windows, and this is the parasternal long axis. So here the probe is aligned along the long axis of the heart, and you can see the structures along the long axis of the heart. And when you move the probe to 2 o'clock position, that becomes the parasternal short axis, where you get the cross sections of the ventricle. And this is the apical 4-chamber view, where you get all the 4 chambers in the vision, in the view. And in subcostal, you use the liver as an acoustic window to see for the 4 chambers in the pericardial sac. So when you're doing this cardiac scan, try to stabilize your hand, make small movements at a time, and you see 2D but think 3D to make, to have a better understanding of the things. And always confirm your findings in more than one plane. Okay. So to make the things simpler, it's better we move from the clockwise from the parasternal long axis to parasternal short axis, then to the apical 4-chamber and subcostal. This way, the chances of missing the things are least. So let's move on to the first view, that is the parasternal long axis. It is usually the first view to obtain, and it gives us the immediate assessment of the general condition of the patient. To obtain the long axis parasternal view, we put the probe along the just left to the just left of the sternum, with the probe indicator towards the right shoulder, that is at a 10 o'clock position. So our goal is to align the probe along the long axis of the heart, and the structures which we can see here are left atrium, left ventricle, left ventricular outflow tract, right ventricular outflow tract, and this is the interventricular septum. And these are the aortic valve and mitral valve with anterior leaflet and posterior leaflet. This is the glistening structure, is the pericardium. This is myocardium, and with this the endocardial lining. And here is there is one anechoic region here, that is the descending aorta. So for the image optimization, you have to slide up and down and try to get the view in which the interventricular septum is horizontal, and you have to try to focus on the aortic valve and the mitral valve. They should be in the center of the screen and in the same plane. And this LV should be in the long axis with AV cusps. They should be symmetric, and you have to avoid keeping the left ventricular apex in the view. So if that is coming, that is the foreshortening of the view. So for viewing this descending aorta, you have to adjust the depth, and so that the descending aorta is also in the view. And for this, we need a depth of around 14 to 16 centimeters. This is the Plaque's view, normal structure and function. What you see here is the right ventricular outflow tract and the left atrium and the aortic outflow tract. They are of the same size. And here you can see the assess for the left ventricular function. So you have to focus on the 3 things for seeing the left ventricular function. One, the chamber size. The second, that myocardial thickening with each contraction. As you can see very well here, that the myocardium is getting thickened with each systole. And the third thing is the movement of the anterior leaflet of the mitral valve. It approximates septum during the contraction, and the distance between normally it is less than 1 centimeter. And you can see that mitral valve and the aortic valve, they are opening and closing normally. So what you can pick in this plaques view are is there any LV dysfunction? As you can see in this video that the chamber is dilated and the thickening is not much. It is decreased. The myocardial thickening with each contraction is decreased. And even the movement of the mitral valve is not much. So the distance between the anterior leaflet of septum of the mitral valve and the septum is more than 1 centimeter. So all these findings, they are suggestive of that there is LV dysfunction. Here you can see that the left ventricle is hyperdynamic here. The chamber size is very small and the anterior leaflet, they are contacting the septum, and there is obliteration of the end diastolic cavity. So here this is hyperdynamic left ventricle. Other thing that you can see in this view is the right ventricular overload signs. Where you find that right ventricular outflow tract, it is larger than the aorta and the left atrium. And you can also see the paradoxical septal movements. One more thing can be seen in this plaques view is the presence of pleural fluid in the, pericardial fluid in the pericardial sac. It appears as an anechoic space between the this pericardium and the myocardium, and if it is not loculated, it generally gets collected in the pendant areas posteriorly. And for this, to differentiate between whether this is pericardial fluid or the pleural effusion, descending aorta is used to differentiate between them. And you can see here that when it is the pericardial effusion is anterior to the descending aorta, and here you can see that this is the descending aorta. This is a case of malignancy, and that patient had malignant effusions, both pericardial and pleural effusion. And this is descending aorta, and this is the pericardial fluid, which is anterior to the descending aorta, and this is pleural fluid, which is inferior and posterior to the descending aorta. So this way you can differentiate between the pericardial and pleural effusion. These are the videos which show that here this is the normal left ventricular function and the EF is normal, and here the left ventricular function is moderately impaired. You can see the chamber is dilated and there is minimal thickening of the myocardium with contraction, and here it is severely reduced, the left ventricular function, and even you can see that minimal pericardial effusion. And here the left ventricle is hyperdynamic. So the pitfalls of the plaques are that only it helps in visualizing the right ventricular outflow tract only. We are unable to evaluate the right ventricular size unless it is severely abnormal, and you cannot see even the right atrium. Sometimes this view may underestimate LV function in under-resuscitated septic or hypovolemic patients, and we have to avoid foreshortening. From the parasternal long axis, now we move clockwise to parasternal short axis, where you rotate your the probe clockwise from 10 o'clock position to 2 o'clock position. That is, now the probe will be, the cardiac marker will be directed towards the left shoulder of the patient, and you move until you get the left ventricular circular. Here you can see that this is the left ventricular cavity. This is the anterior wall of the left ventricular. This is the inferior wall, and this is the septum, interventricular septum, and this is a normal crescent-shaped right ventricle. Here you can see the papillary muscles. This is anterior one, and this is posterior one at 4 o'clock and 7 o'clock position. And here in the parasternal short axis, 3 levels of cross section can be achieved depending on the position of the probe. At aortic valve level, you can see the Mercedes-Benz view, and when you move little caudal, there is a mitral valve level where you can see the mitral valve as fish mouth. When mitral valve opens and closes, it looks like fish mouth, and this is called as fish mouth view. And the third one is the mid papillary level, where you see the anterior and posterior papillary muscles. So we start with the mid papillary level view only, because it quickly, with this we can quickly assess the ejection fraction, the left ventricular function, and any RV overload signs. So from there we move on to the mitral valve view and then to the aortic valve view. So in this parasternal short axis view, we can do the left ventricular eyeballing. That for that to the function to be normal, there is a principal criteria where we have to see for the two things. One is that you have to see for the symmetrical inward movement of the the left ventricular wall and the myocardial thickening with each contraction. So this shows that the left ventricular function is normal. So here, these are the videos showing the aortic valve level Mercedes-Benz view in short axis. And this is the fish mouth view. And this is the mid-papillary. The normal structure and function, what we can see here, let's revise that the circular left ventricle with small crescent-shaped right ventricle, and you can assess the left ventricular function with eyeballing only. And what else can you see here? That you can see for any LV dysfunction where you will see the cavity, the left ventricular cavity is dilated. There is minimal thickening and movement of the left ventricular wall and the septum. And you can also see for any wall motion abnormalities here. Here you can see the left ventricular hyperdynamic left ventricle. So small left ventricular cavity with touching papillary muscles are seen here. And the other thing which you can see in this view is, are there any signs of right ventricular overload? And here you see that the right ventricle, instead of being crescent shaped, it has become large ovoid shaped, and the septum is moving towards the left ventricle during the systole, so causing the flattening of the septum. So this is called as D-shaped left ventricle. And this is also video showing the right ventricular overload, and you can see the septal flattening here too. So this is the normal LV function in the parasternal short axis view. This is the LV function is reduced here. Here the LV function is severely reduced, and here the LV function is hyperdynamic. So from parasternal short axis view, now we move on to the apical four chamber view. It is sometimes difficult to obtain this view, and to get this view, we have to keep our probe on the area of cardiac impulse. So you can see that the probe is along the long axis of the heart with the marker towards 2 o'clock or 3 o'clock position. And here you have to, attain a depth of at least 14 to 80 centimeters, so that you can see the apex of the heart with all the four chambers. Minded that this is this view is the least sensitive to pick the pericardial effusion. So the structures which you can see here are the right ventricular, left ventricle with the interventricular septum, right atrium, left atrium with interatrial septum, the tricuspid valve and the mitral valve you can see here, and this is the pericardium you can see. For the image optimization, you have to center the apex of the heart with both left and right ventricles at the top of the screen, and you have to rock or slide the probe until you see that the interventricular septum is centered vertically, and both the ventricles and atria, they are visualized in their longest axis. So try to keep the mitral valve and the tricuspid valve in the same plane for the better image optimization. This is the normal structure and function you see in the apical four chamber view. You see here that right ventricular is triangular here, and it is the 2/3 the size of the left ventricle normally, and majority of the apex is formed by the left ventricle only. So here you can assess for the left ventricular function, right ventricular function, where in the for the right ventricular function, you see that during the systole, there is shortening of the right ventricle, and this we can measure with the TAPSE, which is the visual tricuspid annular. This is the tricuspid valve, and this is the annular plane systolic excursion. You measure this in the M mode. And you can see both the valves, the mitral valve, tricuspid valve and the mitral valve, they are opening and closing normally. The things which you can pick up here in this view are that you can see for any LV dysfunction, where you will find that the left ventricle will be dilated with decreased mitral valve opening, and the wall motion abnormalities also can be appreciated in this view. And here the LV is hyperdynamic. So the other thing which you can pick up here is there any right ventricular dysfunction? Here you can see that in this video, there is decreased wall motion, and this is the McConnell sign, where we find the mid wall, the mid right ventricular free wall is hypokinetic or akinetic with the hyperkinesis of the apex of the heart. Here you can see that normally we know that the right ventricular rate is 2/3 of the size of the left ventricle, but when the RV is dilated, the severity is like, if it is moderate dilation, then the RV is 60 to 100% of the left ventricle. And when the right ventricle becomes larger than the left ventricle, when you see that it is larger than left ventricle, then this means that RV is severely dilated. And you can also appreciate the movements of the paradoxical movements of the interventricular septum. From apical four-chamber view, if we put our, the footprint more cranially and towards the base of the heart, we can see the apical five-chamber view, where one additional thing is seen, that is the aortic valve and the left ventricular outflow tract. Now, moving on from the clockwise from the apical four-chamber view, now we move to subcostal view. It is usually done in the emergency when we are doing the E-fast examination. Here you place the probe under the xiphoid process, flat against the abdomen, and the probe marker is towards the 3 o'clock position. So here you have to, put a gentle compression here. For that, you can put your hand over the probe too for the better visualization of the image. And the structures you see here are this is the liver, this is right ventricle, this is left ventricle, this is the septum, right atrium, left atrium, and both the valves and the pericardium. And you can see the pericardial sac here. Here you have to move. Sometimes you're not able to see the chambers, then you have to move little towards the right side of the patient, so that you can use the liver as an acoustic window. So always try to visualize the apex of the heart too in the view. The normal things what you can see here is that the liver and the four chambers, the pericardium, the chamber sizes, the aortic and tricuspid valves, and the septum you can see here. And you can, if there is any sign of RV overload, or sometimes you can see for the most important thing what you can see here is the pericardial effusion, or you can see is there any pericardial tamponade physiology, which means that here you can see that the right atrium wall is collapsing during systole, as well as even the right ventricular wall is collapsing during diastole. So this is called as this is a situation where there is pericardial tamponade, right? The pitfalls of this view is that it is the same for the others also, that off-axis errors can occur if you are not at the proper axis. So it is difficult to obtain this view in obese muscular patients with in case of the bowel gas, or if there is any abdominal distension. Now moving on to the IVC, we know it is a vessel that is highly sensitive to the changes in the intravascular status, and it is collapsible, and it varies in size depending on the respiratory changes in the this intrathoracic pressure. So the assessment of IVC helps us in diagnosing the volume status of the patient, and we can do the serial monitoring of IVC. We can repeat, and we must repeat after each intervention, and it also can be used for predicting the volume responsiveness. Obtain the this IVC view, we can use both the probes, the curvilinear as well as the phase direct probe, and it is usually put in the subcostal area to visualize this, and the indicator is towards the 12 o'clock position. And we know that the IVC is on the right side of the aorta. So sometimes, there is sometimes, most of the times, there is a confusion between aorta and the IVC. So always identify both of them, aorta and IVC, to ensure that you are seeing the IVC only. And the two things which are to be looked for is that you have to focus on where the IVC enters into the right atrium. So this also confirms that you are seeing the IVC only. And the second point you have to focus on, that you have to see for the hepatic vein joining the IVC. So this is one view where you can get the IVC for the IVC. Sometimes it is not this subcostal view is not obtainable. Then you can go for there is a second approach which is called as rescue view, where you put the probe on the right anterior axillary line, and then you try to move anteriorly. This is the right lateral coronal plane, and with the marker pointing towards the head. Here you try to see first the liver, and just adjacent to the liver you can see IVC, and here the aorta is also seen, which is running parallel and inferior to the IVC. So this is the rescue view. So normal IVC size is 1.5 to 2.5 centimeters with some variation with the respiration. Now the point is where to measure the IVC. So there, as you can see in this picture, so this is the right atrial and the IVC junction. So you have to move 3 centimeters from this junction, and you have to, I told you that you have to look for the hepatic vein and the IVC junction too. You have to measure it at 1 to 2 centimeter distal to that junction. Why? Because this is the area, this is the point where the IVC, the changes in the pressure, the IVC is most sensitive to the changes in the pressure that result from the respiration. And if you measure the IVC at the junction of right atrium with IVC, here you can get the pseudo collapse of the IVC because of the diaphragmatic pull. So this is the best area where you have to measure the IVC diameter. And for this you have to first you have to select the IVC, then you have to activate the M mode and drop a cursor line on the area of interest, and then M mode shows the variability of IVC diameter with respiration over time. And you can measure the maximum and the minimum diameter of IVC, which is represented on the M mode tracing. You can see here, this is the B mode first, and then you activate the M mode and drop the line along the line of interest, and then you again press the M mode using the touchpad. And here you can see that this is the maximum diameter, and this is the patient who was spontaneously breathing. And so we know that in spontaneous breathing there is inspiratory collapse. So this is the inspiration and this is the expiration. Now using the caliper and select keys, you can measure the diameter, maximum diameter and the minimum diameter. So here in this video, you can see the maximum expiration diameter is the 1.29, and the minimum diameter of IVC is, which is during the inspiration, it is 1.04, right? So in spontaneous breathing, we know that there is inspiratory collapse. Why? Because inspiration causes decrease in the intrathoracic pressure. That increases the venous return and to the heart, and that causes the collapse of the IVC, and the opposite thing happens during the expiration. Hence, in spontaneous breathing patients, we measure collapsibility index. So that is equal to maximum IVC diameter, that means during expiration, minus minimum IVC diameter divided by maximum IVC diameter into 100. This way we get the collapsibility index. The considerable differences they exist among various authors regarding the IVC and the right atrial pressure correlation. So the American Society of Ecocardiography, they have recommended a few values which can be used in guiding the intervention. So here you can see that IVC diameter, when it is less than 2.1 centimeter and the collapsibility is more than 50%, right, it is suggestive of that right atrial pressure is 0 to 5 mmHg. And when the IVC diameter is more than 2.1 centimeter and the collapsibility is more than 50%, this suggests the right atrial pressure is 5 to 10 mmHg. And when the diameter is more than 2.1 and collapsibility is less than 50%, that suggests that the right atrial pressure is raised and 10 to 20. And this is suggestive of that there is fluid overload. In contrast to mechanically ventilated patients, inspiration distends the IVC. So here we calculate distensibility index, which is equal to maximum IVC minus minimum IVC divided by minimum IVC. Remember that in collapsibility index, this denominator was maximum IVC. So, and that you have to multiply this value by 100 to get the index, and the distensibility index of more than 12 to 18% suggests that the patient is fluid responsive. Another use of IVC is that we can predict the response to IV fluid bolus. Here you have to put the patient in a semi-recumbent position with head elevation of 45 degrees, and you obtain the maximum and minimum IVC diameter, and then you lower the upper half of the body horizontal with the legs elevated to 45 degrees for 1 to 2 minutes. And this is called as a passive leg raising maneuver. So there is also called as auto preload challenge, that what happens that the venous reservoir of 300 to 400 ml that moves to the central circulation, and you can assess for, then you repeat the maximum and minimum IVC diameter to see for any change in the hemodynamic parameters. This is this carries low risk of pulmonary edema because not even a single drop of fluid is being given to the patient, and it is reversible. You can repeat it, and this is non-invasive. But the important thing is sometimes, there can be error because of the patient is severely hypovolemic, and you can't do this in case of increased ICP or increased intra-abdominal pressure. So when you repeat the maximum and minimum IVC after doing this maneuver, if the hemodynamic parameters they improve, that suggests that patient is volume responsive, so you can give the fluids to the patient. But mind it that before giving the fluid to the patient, always assess three things. Not only IVC, but you should always assess the heart, the cardiac scan, and then look for the B lines in the lungs, and then only you can then only you should give fluids to your critically ill patients to avoid the consequences of the fluid overload. With this, we finish our the basic windows of the echocardiography and the IVC assessment. Thank you. Have a great day.
Thank you, Dr. Sweetha, or Dr. Seema, sorry, for the talk on 2D echography and the IVC and IVC diameter as well. With this, I request the last speaker, Dr. Ashish Chakravarty, who is senior consultant and head of the pain management in our group of Artemis Hospital Neuroanesthesia and Neurocritical Care team. He is going to present how to place a central line, which is our day in and day out procedures in OT as well as in ICU. Over to Dr. Ashish.
Senior consultant in neuroanesthesiology at Artemis Hospital, Gurugram, and I am going to present to you ultrasound guided central venous catheterizations. Now, this is a procedure which is very commonly performed in intensive care unit settings. Since the IJV is the most common route employed, it is better and it is important that you learn this procedure first and learn it well before you move over to the more complicated procedures like axillary and the subclavian vein routes. Another thing that I want to point out is that I am a strong proponent of the in-plane technique. So in this video, I'm going to restrict myself to the in-plane technique. And even I would suggest to you that you restrict yourself to the in-plane technique first. And as you gain more and more amount of expertise, you can move over to the more complicated procedures like placement of femoral arterial line, and then maybe move over to radial. But those things come later. First, learn this procedure well, which I'm going to. Right. So the procedure starts with insulation of the carotid artery and the IJV in the shock axis. Confirmation of the artery and the vein is done by using the Doppler and noticing the compressibility of the vein. So just now you have noticed what is the Doppler pattern of the artery, and this is the Doppler pattern of the vein. Remember this pattern when you convert the short axis to long axis. See how the venous compressibility is very much evident when compared to the arterial. Now turn to the long axis and confirm that the insulated vessel shows venous pattern on Doppler. So that's the vein in view, and it shows a venous pattern there. Now insert the needle under ultrasound guidance in long axis till the tip of the needle is seen completely inside the vein. So you can see that the vein is coming along the track. The whole length of the needle, including the tip, is visible. And the needle is seen to enter the vein. And that's the tip of the needle, which is now seen completely inside the vein. Now insert the guide wire under ultrasound guidance. While you are doing so, always keep your view of the guide wire, and you would see how beautifully it goes through the needle inside the vein. Having done that, insert the dilator. While inserting the dilator, please make sure that it dilates only the track but not the vein. So as I am inserting my dilator, I make it a point to see that it is dilating only the track but not the vein. Now remove the dilator and insert the catheter. The insertion of catheter is also confirmed real time under ultrasound guidance. Having done that, remove the dilator and confirm that your catheter is in situ, inside the vein. That was the video regarding internal jugular vein catheterization under ultrasound guidance. I would advise you to take the other venous cannulations and the more complicated procedures in the next step as you further master this technique. So but essentially always remember that the principles remain the same. You would always confirm the vessels first, whether it is a venous or whether it shows the venous pattern or the arterial pattern. The insertion of the needle has to be real time, preferably in long axis view. The insertion of the guide wire has to be in real time under vision, and subsequently the catheter. If possible, also insert the catheter under real time vision. If required, please do not hesitate to take the help of a person to hold the probe for you. And with repeated practice, I'm sure your confidence and your expertise on ultrasound guided line placement, so as how it is called, will improve in future. Thanks a lot. Thank you for watching. Thank you.
With this, this session was really exhaustive, but very informative. And that is the end of this. Now, let's see if there is any question or not.
We have answers the questions in the chat box. There were 2 questions which we have answered in the chat box itself. If there are any questions, we would like to, if the participants can unmute themselves and ask the questions as well. It's we finished in time, so it's 1:45 exact.
Yeah, exactly in time.
So I thank my team members to present all these lucid presentations. These all the videos are from our institute only, from our machines. We have not taken help from any other source. So these are our videos from our ICUs, and we hope to do this physical workshop very soon in near future, as we have done in the past as well.
Any question from any of the delegates? I don't think there is any question.
There are questions in chat box, sir. Can you please check, sir?
I have checked the question and we have replied to those questions already.
Okay,
There is one more question. What if you dilate the vein? Also, any serious complication? Please answer that.
Dr. Ashish, you want to take it? Okay.
Yes. So I have a question. I think the question is relevant to me. What if we dilate the vein also? Okay. So basically, it's not that, it's not uncommon to dilate the veins, definitely. But what is preferred is that you do not dilate the veins, because if you dilate the veins, what can happen is, and especially if the patient is having deranged bleeding profile, deranged INR, then you are going to have a very big hematoma. So ideally, that is why I said that the dilator should also be inserted in real time under ultrasound guidance, and you should stop short of the vein. You should not insert your dilator inside the vein. That is
Ashish, you have muted yourself. You have muted yourself.
So what I was telling was that in case you have accidentally dilated the vein, I mean, it should be accidental and not intentional. So let us say that you have accidentally dilated the vein. You can very well put in the catheter and then keep it compressed for for approximately around 2 to 3 minutes. So at the end of it, just check for hematoma. If the hematoma is not there, consider yourself lucky. But then definitely, if the patient's INR or the bleeding profile is bad, then you may be in trouble. And the second question is any serious complications. So basically, the point of doing these cannulations or catheterizations under ultrasound is to avoid complications. The only thing what I remember, I mean, it has not happened in my experience, but there has been an instance where the guide wire was put in, and of course, you do not see the guide to the extent the guide wire has been inserted. So there may be a possibility that it may go and pierce through the ventricle, the ventricular musculature, and the patient may have a pericardial effusion. I mean, pericardial tamponade. So especially so if you do not insert the J-tip, the end which has a J-tip, if you turn the wire around, the guide wire around, and you put the other end, there is high possibility of puncturing the ventricular musculature and resulting in pericardial tamponade. So you should be careful about that.
So the whole idea of ultrasound is to prevent complications. And what should be the message from our team is that do it till the end. It's not that you have cannulated the vein and you just stop doing the ultrasound any further. You have to do it at every procedure so that you avoid the complications which are listed. So that's the take home message from our team as regards cannulation.
Okay. With this comes the end of the very useful and very practical session of the workshop. So thank you all. Thanks.
Okay. Thank you.
Thank you.
एक और question था. There was yet another question. I mean, if that has to be taken, we will be.
You can.
Yeah.
So ultrasound. The question was whether ultrasound is enough to place ICD or X-ray or CT is required. So, if you are doing the procedure under ultrasound guidance, and you have seen the ICD placement, and you find that it is adequately placed, then you need not do a X-ray or CT. Only if you are doing it as a blind procedure, you need some sort of confirmation. You have not had ultrasound for confirmation. That is why you do an X-ray or a CT. So our take is you do ultrasound for ICD placement. You do not require an X-ray or CT. But then if you want to have a documentation, only for medical legal purposes, you may do a X-ray or CT. Or if you have saved an image in which the patient's details are there in the ultrasound, that is good enough. So that is our
thing is that you need to have a documentation. You want to have it in a form of an X-ray, or if it in a form of an ultrasound, it will be good enough. You can do it.
Any other question from anyone? It was really a very practical point regarding pneumothorax.
Okay, so if there are no other questions, we can wrap up the workshop.
Okay,
Yeah.
thank you.
So, okay, thank you. Thank you very much. Let's wrap up. Thank you.